Welcome to the I Spy with My MyOI podcast. I am your host, Brittny Sierra. I am a certified oral facial myologist, registered dental hygienist, and lifelong learner. My goal with this podcast is to expand your knowledge of oral facial myofunctional disorders and to bring you up to date in current literature so that together we can get to the root of the problem. You ask, we'll answer by collaborating with true pioneers and specialties associated with the myo world. Join me on this journey as we dive into the life-altering world of tethered oral tissues and airway space. Let's do this thing. Quick disclaimer, all content expressed on this podcast are the views and opinions of the speakers and is for informational purposes only. You should not rely on this information as a substitute for, nor does it replace, professional medical advice, diagnosis, or treatment. Because every person is so unique, you should always consult with your specialized healthcare professional. Dr. Scott Siegel is a board-certified dual-degree MD DDS oral and maxillofacial surgeon. Dr. Siegel is a fellow of the American College of Surgeons, International College of Surgeons, and the first oral and maxillofacial surgeon awarded fellowship to the American Academy of Pediatrics. Dr. Siegel is also an active member of numerous medical and dental professional organizations. Dr. Siegel has over 25 years of experience as an oral and maxillofacial surgeon and has devoted the past 18 years to treatment of issues related to tethered oral tissues. He has performed over 30,000 tethered oral tissue surgical procedures to date. Educated at the State University of New York, at Stony Brook Schools of Medicine and School of Dental Medicine, Dr. Siegel maintains a private practice based in New York City and Long Island, New York. Dr. Siegel is internationally recognized as a pioneering laser TOTs surgeon. During his surgical residency and in private practice, Dr. Siegel was mentored by world-renowned pediatric surgeon and tongue-tie pioneer Elizabeth Betty Corliss, MD. Dr. Siegel has been treating TOTs patients for the past 20 years, ranging from infants to adults. Dr. Siegel lectures internationally and conducts clinical research and publishes in various areas related to TOTs, including aerodigestive disorders such as aerophagia-induced reflux. Dr. Siegel is currently working as a clinical investigator in 2 major IRB-approved clinical research projects. Dr. Siegel is working in collaboration with the Department of Biomedical Engineering at Columbia University and Tel Aviv University in understanding the kinematics of tongue movements in infants, children, and adults with ankyloglossia. Dr. Siegel is also working with the Child Development Lab, City University of New York, investigating objective parameters of infant sleep before and after lingual frenectomy. All right. Well, good morning, Dr. Siegel. Thank you for coming on to the podcast. I'm very excited to have you and for everybody to hear from you. Let's just get into it. So I know a little bit, obviously, about the procedures and everything that you do because I refer some patients to you. But let's talk first about what tools you use to do the procedures and just a little bit more about the process in general.
Yeah, sure. So basically, I primarily use a carbon dioxide laser, which I've been using for this is going on my 20th year. In that specific type of laser, to perform frenectomies in all ages, basically. And we'll talk more about that. But I started out early in my training using scissors, and I transitioned to lasers pretty quickly. And that's my primary, instrument of choice for the surgery.
Now, what do you feel the pros are of using a laser over how you used to do it?
So, having it done both ways in my own practice, I find the specific laser I use is a light scalpel, carbon dioxide laser. For me, and I think it seems like the majority of people practicing and seeing large volumes of patients for the procedure, laser versus scissors seems to be better in a few different ways. I think the primary way is that it coagulates or stops bleeding or prevents bleeding as it's cutting. So you tend to have a more precise dissection, able to see a little more clearly, have a little more accurate procedure. When we're doing the procedure, we see probably less postoperative pain, nicer wound healing. some secondary benefits is the laser actually sterilizes as it's cutting. So even though infection rates are really next to zero, it's an
Right.
added benefit.
Yeah, absolutely. So let's talk a little bit more about your practices. So you have a practice in New York City and a practice in Long Island. So what age groups do you treat?
I basically treat all age groups from right out of the womb up through senior citizens. And I've had, I have a very large pediatric practice, and I am a fellow of the American Academy of Pediatrics, but I treat a lot of infants with feeding difficulties, breast or bottle feeding difficulties. We see young children with feeding difficulties, oral myofunctional issues,
Mhm.
airway issues. So anything that encompasses tethered oral tissues. And we've had senior citizens with sleep disorders or sleep disordered breathing, dysphasias where they have swallowing disorders that actually benefit from the procedures. So you name it, we do it. We see from infancy up to the senior citizen.
That's awesome. Can you share a little bit on experiences that you have with breastfeeding moms that come in, I'm sure, with a lot of frustration when you first meet them? And then, after you have the procedure done and they come back for their follow up post frenectomy, just like the world of difference that everything has been for them.
Right. Yeah, it's just like with everything we choose, the patients and, whether or not there are indications for the procedure itself. But there's a big frustration, or then I guess we'll talk more about it, but there seems to be either a gap in understanding about these things from general medical community or pediatric community, and what we see or the lactation consultants will see, or like you would see in your practice with speech therapists. So many moms come in very frustrated or feeling beaten down, and like nobody's believing that they're struggling or having difficulties. And many times they find the solace in dealing with a lactation consultant who understands, and then they wind up coming to see us, and we have a full understanding and empathy. And I think that's the biggest thing. They don't feel as isolated, so you can
Right.
understand what they're going through, show them what they're dealing with from a functional and anatomic standpoint, and realize that we do have high success rates. We do choose our patients as best as we can. The majority of them do have very good results. On occasion, some need some more work, and we can talk about that more, because we talk about pre-op work and therapy and post-op, and it's not a silver bullet. So the procedure itself that we talk
Mhm.
about, not always a silver bullet, but overall feedback, especially from the breastfeeding mom community, is that they're very happy. Babies start to feed more efficiently, less pain on mom when they're eating, and just an overall happier family. And we're treating the family, not just the babies.
Absolutely, 100%. So let's talk a little bit more, because you kind of went into that, about the pre and post op and what you think the importance of, either body work or myofunctional therapy is pre and post op.
Yeah, it's been interesting in the span of my career of doing this for 20 years at this point. In the past, at least, I'd say 3 to 5 years has been a bigger push to understand what we're really looking at here. And it's not just the tongue or lips or oral, functional muscles in isolation, although that's an important part, but there's connections and there's body connections. And that's being elucidated even further, by our coworkers in physical therapy, occupational therapy, chiropractic, and people who deal with the body, and understanding the fascia connections. And we see better results, and we're trying to get the science behind that, but better results in those patients who do some form of pre-op therapy, whether it's, the focused oral myofunctional therapy in conjunction with a body component where we're working, and you can talk all about that from your standpoint, but we do,
Yeah.
and I'm not going to get into those areas, but we see better results, post-op, from a standpoint of functional results improving, and as far as the other things that we see, something popping up here. The other results that we see is less of this, quote unquote reattachment, that
Hmm.
people talk about as scarring, or, having to revise or redo a procedure.
Right.
I actually see less pain in a lot of these patients post-op too that have been doing pre-op therapy.
So how would you explain, because I get a lot from my patients that ask me, Well, because they say that we can't quote unquote stretch the frenum
Right.
itself. So, what would you say the therapy prior is doing and how it's aiding you? Do you feel that it's just kind of helping to release some of that tension?
Yeah, I think there's definitely a release of tension. I also see, from the body standpoint, we see that even when they release the tension, once we release the tongue or the other tethers, they're more likely to stay released. We find that, either muscle memory or function or stretching of the muscles is improving as well as the fascia. Intraorally, we see, better understanding of tongue placement. We see that muscles and their structures are actually, more toned,
Mm-hmm.
and they actually progress much faster,
Right.
less disorganization afterwards.
Right. I always tell my patients, I'm like, the doctor's giving you all of this increased range of motion, but your body's not going to automatically know what exactly to do with it.
Exactly.
And
And
especially when we have, these patients that already have some kind of sleep disordered breathing, we don't want the tongue to fall deeper in the back of the throat. We want it to be able to have an idea at least already, or the muscle strength a little bit to be able to rest up on the roof of the mouth.
absolutely, and that's what the studies keep showing. Dr. Zaghi's been really pushing that in the forefront of publishing that and seeing the benefits of that. And it really is holding true in clinical practice. We see
Right.
the changes in clinical practice. And I can say, just based on my own experience of doing it for years without having pre-op therapy and just doing the procedure and then working on a post-op, now that we've instituted these pre-op regimens, we see better results coming in and
Right.
happier patients.
Yeah, and we love happy patients. So,
Right.
um, what's your advice for even like me as an oral facial myologist, or really any provider that is on the same page as we are, but the pushback that they get from other medical professions? Say, you have a patient that comes in that says, "Oh, well, my pediatrician, never pointed that out. My kid's 5 years old. What do you mean he's tongue tied?" Or everybody's diagnosing all these tongue ties. Tongue ties a fad, or, again, what's a posterior? I mean, like I said, I'm a hygienist as my background. I never learned about posterior lingual frenum ever. And even as far as anterior frenums go, maybe like one slide on ankyloglossea. But besides that, I mean, I never learned the implications of it or anything, or how it relates to anything, just overall patient quality of life.
Right. I mean, I went to dental school. I went to medical school. I trained as an oral and maxillofacial surgeon, and I got zero on it as well. When I went into private practice, one of my mentors happened to be a tongue-tied surgeon, Betty Carrillos, who developed a classification system. And when she first mentioned the term of posterior tongue tie to me, I had no clue what that meant. And I thought it was like in the back towards the throat
Mm-hmm.
somewhere. So even, coming out thinking, and I always go back to that when I'm trying to communicate with other professionals, really having that as my benchmark. I have to realize that most people have no clue what we're really talking about, because
Right.
it's not part of basic medical or dental education still. So what I do is really educate. When I get a family coming in who's very frustrated because they found that their pediatrician missed things and they're only looking at weight gain, or they're calling something mild, whether it's a speech person or the type of patient that you'll see, they go back to their doctor saying, no, it looks mild, you can stick your tongue out, you're fine. When I really evaluate these patients, majority of my consultation with them is education. And I'm really showing them what I see, and I start to talk about the experience and the research and the literature out there. And when they understand, that this is not a fad, and I will talk about that to them, I say, it's not a fad, but we have a more clear understanding about the connections and what untreated ties can actually cause over a lifetime. And there's been more research and experience, but the awareness is out there. Part of that is from social media. Social media has pumped a lot about that, and there becomes this, heightened sense from pediatricians that this is a fad sort of thing. This is a new diagnosis. But the reality of it is we don't know if there is an increased incidence. It seems like there is, but
Mm-hmm.
this has been something that's been there all along. We've been kind of just letting it go under the radar and treating end result symptoms, or more symptomatically, versus trying to get to the underlying cause.
Now, do you find often that, say, with revisions or whatnot, or people come in that, had releases done prior, that you end up having to do a revision because maybe they got the anterior portion of the tongue tied, but again, didn't realize that there's a posterior component to it?
Right. Yeah. There's the procedure itself, although, from a surgical standpoint, is a pretty straightforward, simple procedure. There's a lot of nuances that go into it. And it takes a lot of experience to understand actually where you're cutting, what you're cutting, and doing a full release. So in my practice, we see a lot of, redos, as we call them,
Mm-hmm.
because they were not done correctly. So that is, and trying to get that, there's no uniform training about these or education. There's a lot more going on now with some laser education
Mm-hmm.
conferences, or some people doing mentorships and things like that, to try to help train people. But we're trying to institute that into residency training as well,
That's
so that they
awesome.
have a better understanding.
Yeah, because that's kind of something that I deal with. There's a few surgeons that I refer to, again, you being one of them. And, I'm in Cheshire, Connecticut, but, I try to explain to people, especially if you're going to say like a family friend that's a periodontist or oral surgeon or, whatever. If they already don't know what I'm referring to when I say that you think there's some kind of posterior lingual restriction going on, I don't feel comfortable with my patients having it done by certain people. And, it's hard because, again, I feel like there's just not enough of people, at least in my area, that are really aware of anything. But I tell my patients all the time, you don't just want to go to anybody, because more than likely you'll probably have to have it redone again.
Right. And that is a big frustrating, point, because, and I see even with my own colleagues, they dismiss it as a very quick, easy procedure, but they're really not understanding the anatomy and the function that we're trying to achieve.
Mm-hmm.
And then, if a patient does it, they go to a trusted surgeon or somebody that they know, and it's done not correctly, and they'll say, "Oh, see, it didn't work," and they didn't get the optimal result, which
Right.
then, makes, all of us look bad,
Right.
saying necessary procedures that don't work.
Yeah.
So it's a tricky thing. Trying to educate, trying to get the people. I'd say, but we're seeing. I kind of see an explosion of the number of practitioners actually doing a better job in the past couple of years,
Yeah,
even.
that's awesome. Absolutely. Can we talk a little bit more about the consequences that somebody might face if their tongue tie or any, real tethered oral tissue is left untreated, like in terms of, sleep or speech or craniofacial
Right.
development, all of
Yeah.
that?
When we see these, and that's, when I do a consult, especially on an infant, I always go through that lifelong span of what can happen. And so a lot of families come and say, well, listen, if it's just about the breastfeeding, we'll just go to a bottle or do something else. And I said, well, it's not just about the breastfeeding. There's a lot of other implications that can occur. It doesn't mean they absolutely will. But in my own experience, the experience that I share with my other colleagues doing this around the world, is we see patterns. We see a lot of these kids follow similar patterns. So in a time progression thing, I kind of lay it out for them. I say, many times you'll see a newborn, an infant or baby struggling with breast or bottle feeding. They have a disorganization. They have inability to elevate the tongue fully. They can't get that good, wave-like motion going on. They struggle bringing breast tissue in. And then we talk about tongue position and breast tissue as far as helping prevent malocclusions, helping flatten the palate out and open airways up. So I say, if you don't do that, these kids are more likely to have other issues as they get older. And I kind of lay that out as I map it out for them. I said the next age group we'll see is when they transition on to solid foods, because again, they don't have that full, range of motion of these, tissues. They may struggle with solids. They may get labeled as a picky eater when in fact they just physically can't swallow and bring the bolus of food to the back of the mouth. The next age group we're seeing, and we're seeing more and more speech therapy people starting to screen out for tethered oral tissues, 18 to 24 months. And we see a lot of kids coming with articulation disorders. With the lip ties, they struggle with certain letters, where they, struggle with the labial or dental sounds, the M's, the B's, the F's, P's. The tongue, they struggle with certain letters like R's, L's, S's, and T's. And many times I'll be describing these things, and the parents are like, "You're just describing my other child. You're just
The light bulb goes off. They can name
the
like
light
five
bulb goes
people.
off." The next thing we'll start to see, as far as we're watching the growth and development of the jaws and the face, and it's all like a movie. It's all continuous. We'll start to see these kids develop the high arch, narrow arch palates. Many of them start to need palate expansion with braces, or they have diastemas from the lip ties. They develop maybe retrognathia. They start with the mouth breathing. They start this whole series of things that we see. They develop those adenoid facies, forward head posture, which it's a whole chain reaction. And then we start really getting into the sleep disorder breathing, the sleep apnea, which enlarged tonsils and adenoids. When I kind of lay it all out to them, they're like, whoa, it all makes sense. How come nobody else even thinks about that? We see, and I can't give you scientific proof, we see a lot of these kids having ear infections that, more so than the average person without a tie. We think that there may be some, not only the airway, but eustachian tube dysfunction with the disorganized swallowing. So, but we say the end result, long term, a lot of these people have, neck strain, TMJ problems, sleep disorder breathing, obstructive sleep apnea. When I lay all these things out, and the family's like, you just described my son, you're describing my husband, you're describing all of these people, the light bulbs go off and they start paying attention. And many times what happens, a lot of these families go back to their doctors and the pediatricians, and they start to educate. And some of the light bulbs have gone off for some of my pediatric referrals that way. And
That's amazing.
They had no idea. I don't know what I'm looking at, actually, and we've actually seen an influx of doctors bringing their own children, and ENTs bringing their children, and pediatricians, and wanting more education about it.
Yeah, well, like I had just made, I had just made a post on social media yesterday about not, you don't know what you don't know.
Right.
So, unfortunately, there's a lot of people that are just closed off and don't really want to know, but I feel like there's always something new to learn. And, why not be open to it if it's going to help your patient?
Right. There was, I was just at a conference, a couple of weeks ago in Florida, and there were a couple of slides that were talking about that. There was, one of the docs put up, I forget which doc, I always like to give credit, but, it was a quote from Albert Einstein. It's like, the mind is like a parachute. It can't function if it's not open. And the other thing a lot of times we hear is that, I don't believe in ties. And there's a pediatrician, Dr. Rajiv Agarwal in Arizona. He's like, when I talk to my colleagues about it, this is not a religion,
right?
Not something you believe in or not. It's either there or it's not. He's like, do you believe in meningitis? It's there. So we just have to kind of really focus on trying to educate, trying to get some standardized ways of communicating and understanding what we're looking at. And, the terms of posterior, anterior get very confusing for a lot of people, and having some kind of classification systems that make sense and you can communicate with other professionals.
So let's talk a little bit about some research projects that you're currently involved in.
Right. We're always continuing research. Right now we have two projects that we have IRB approved with some bigger institutions in the city here. The first one, which we've been working for a couple of years with the Department of Biomedical Engineering at Columbia, is we're actually having the biomedical engineers analyze our ultrasounds. We're doing ultrasounds on infants, breastfeeding infants before and after frenectomy, and looking at tongue organization and motility. And what we've been finding is that there's an increase in tongue organization immediately after the procedure. And they actually mathematically can graph this out, giving us some objective data points to say, yes, we can actually see it with the math. We can see it physically. We actually have them at some point. I've shown it at some conferences. But when we look at the tongue before doing a frenectomy, many times the tongue's all over the place. It can stick out, it can move side to side, but it can't get that organized wave, peristaltic wave-like motion. We're actually able to actually physically show that it is improving, not only on seeing the ultrasounds, but they actually graph it out mathematically. So you can see the statistical, difference that way, and that's an objective way. We have difficulties in our field of trying to get the types of level 1 studies that pediatricians are looking for. It's
Right, because how
the
are you going to not provide treatment that's needed to
that
infants that are struggling?
right. So that's one way we're doing, and that's we're starting off with the infants. We'll look at different age groups. We'll look at longitudinally, long-term impacts as well. So that's one study that we're getting moving along. I actually get some good data at this point. The next study that we're doing, we just started recently, is we're looking at infant sleep before and after lingual frenectomy. And we're actually looking at some objective parameters. We're looking at salivary melatonin, salivary cortisol, actigraphy. There's a little watch that we put on the babies looking at movement, and looking at the brief infant sleep questionnaire, so we get parent input before and after. So we're in the early stages. We're still in the data collection phase. We have some early results that I just presented, and we are showing some improvements, objective improvements in sleep quality. We are actually waiting to look at some of the cortisol and melatonin levels at this point forward too. And that's with the in conjunction with the City University of New York. Actually, one of your colleagues, Ruth Marciliani, she's also a hygienist, oral myofunctional therapist, is kind of leading this study.
That is just so awesome. What about, I know that you've done some work about airphagia-induced reflux. If you want to talk a little bit more about that as well.
Yeah, one of the things that we had seen over the years, kind of by happenstance, is the reports of parents after doing these procedures, especially the breastfeeding infants that were coming in, being diagnosed with reflux, quote unquote, is that after we do these procedures, their reflux symptoms were disappearing within the time frame of doing the procedure. So usually within the first few days, up to the first 1 to 2 weeks of doing these procedures, up to the point where many of these moms or the families were actually able to reduce or taper off or stop their baby's reflux medications. So we kind of studied a little bit more, and just, getting feedback from our colleagues worldwide, we're all seeing the same thing. So we looked at, I was able to publish it. I presented it a few years back to the American Academy of Pediatrics at their national conferences, putting it up there as part of the differential diagnosis for babies being treated with reflux. One of the things that has us concerned is that there's a very large amount of infants that are being treated with reflux medications. And these reflux medications are not specifically made for babies. They're more of the adult or, child medications, and they just kind of monitor or adjust their dosages. There's been study after study looking at the, potential deleterious effects of these medications. And one of them was just taken off the market because of, cancer-causing agents found in their medications. And there's been major studies looking at allergy rates have been increasing in children, and there's been increased risk of bone fracture. One of the issues with the reflux medications is it changes your gut biome and the bacteria, and actually makes the kids more prone to developing multiple allergies. So adding this to part or a piece of the, the whole diagnostic criteria for pediatricians and GI people, before just having a knee-jerk response to put them on a medication, check for ties in the mouth. Some do. I have some GI people now checking. It's still not where we want it to be, because we were seeing, in my own studies, we were seeing 50 to 80% of the babies were getting improvement. I have other colleagues saying that it's higher, it's 80 to 90.
And that's a 50 to 80.
And that's
that's
a
amazing.
significant number. So if we can help, avoid not only the reflux issues, but help all of those other issues that we just talked about lifelong, look at the risk versus the benefit. The true risk of doing these procedures is pretty low. It's not that it's without risk. There are reports of, issues with bleeding, and, there's been a couple of worldwide reports of deaths. And we find that it might be because of people that weren't sure or not knowing what they were doing, but it can happen.
Mm-hmm. And what about as far as acid reflux goes for adult patients? So your adult patients that are coming in that you're doing releases on, do you find that they have improvement with acid reflux?
We are seeing that, and I don't have a large series, but we do see it. whether or not it's aerophagia, whether or not we're changing, vagal nerve issues, or I think there's some issues with the parasympathetic system that we're helping change, because we see those areas, change kind of when we do these releases, that sympathetic tone drops and the parasympathetic kicks in. We see people do complain less of reflux symptoms. We do have adults, I'm sure you see it in your practice with the oral myofunctional disorders. A lot of them do swallow air, and they do have airway, and we do see reductions in that. So.
All right. Well, thank you for all of that. Is there anything that you'd like to talk about specifically with the listeners? Any advice you might have, whether it's for families or other healthcare professionals?
I think, the biggest thing is to keep an open mind and do your research, especially, when going to a practitioner. I think you got to do your due diligence, really research the practitioner. A lot of times you'll find online reviews, and I think those are some of the best things. Social media helps guide that.
And I mean, there is, research out there that supports, having these procedures done. I know that, my families that I have that are a little bit on the border, because I'm the first one that's really pointing this all out to them. I mean, sometimes I think I probably overwhelm them with the amount of information that I send them, but that's really what people kind of rely back on.
Absolutely. So. I wind up having to email families or other doctors, lots of articles or,
Yeah, like I'm not just saying this, like there's actual research behind it.
Exactly. And that's the biggest thing, is that I try to say, this is not hocus pocus. We try to give you what is out there, the best current research literature that seems valid from, a medical or scientific standpoint. Give it to them, and all you can do is educate, give them the information, and they make their informed decision. And that's the majority of what I do, is just educate. The procedures itself take up very little time. It's all of the talking and education, which I think all of us in this field, we just love to do, because we're all in the same boat. It's very exciting because we see the changes. We see the positive changes going on in our patients. We get the feedback from them, like, I can't believe, what a difference this has made in my life, from the adult patients especially.
Absolutely, 100%. And, I'm working currently with a man that is in his, I believe he's early 70s. I can't really remember his exact age right now. But he's seeing, tremendous results. People will say, well, I've been living with this for 60 odd years. Like, is it really something that I need to have done? And again, the results and the positive, impact that it has on their lives. I think I love listening to patient feedback, because I love, like, I have one woman in particular, she actually has done a video testimonial for me. And she's like, I just can't believe it. She's like, literally from the second that I left the office, when I had the procedure done, like, I started noticing, positive impacts.
Right. And I think that's the biggest thing. And I get the feedback from the families, my baby or my child's a completely different child. I can't thank you so much. And even the adults, like, I didn't know what I didn't know. I didn't know what I was living with until afterwards. And, you were right. And so that's
you always have those patients that, they'll come in and you point things out to them and they're like, I don't really think that's me. And then, like, they go home for the next week and then you see them again. They're like, you know what? You're right.
Yeah. And that's it. You're educating them. And it's not that you're, I'm not pushing you one way or the other. I'm giving you all of the information based on what's out there scientifically in my own experience in my practice, and you make a decision. And
well, thank you so much. Yeah. What were you going to say? I'm
for
sorry.
People like yourself doing these things are very informative, and getting it out, spreading the word.
Yeah. And that's my hope. Again, other, healthcare professionals, families, anybody really that can benefit from it or know somebody that can benefit from it. I mean, this is, again, what we're passionate about and what, we believe in, and we just want to get the word out there. And it's just so important. Right. And, you are doing such amazing work. So thank you so much for everything that you bring to this amazing field. We are so lucky to have you.
Likewise, Brittny, I feel the same exact way. We're all in this together,
Absolutely. Thank you so much for coming on, Dr. Siegel. And hopefully we'll have you on again at some point.
Sounds great.
Thank you for listening to today's episode of I Spy with my Maya Y. If you want to hear more about these episodes, leave a review on Apple Podcasts or feel free to contact me at bsierra.omt@gmail.com. Don't forget to subscribe as well and let us know of any subject or guest speaker you'd like to hear from. Help spread the word by sharing today's episode on your social media page. You can find me on Facebook at CT Oral Facial Myology and Instagram handle CT_oral facial_myology. Everybody have a wonderful day.